Okay, good afternoon, everybody, and welcome again to the webinar series from the National Orthopedic Alliance. And today we're in part 2 of the discussion around the integrated care systems, what's happening. It's pretty timely because the bill went to the second reading yesterday. And this follows on from our June webinar where we had a couple of speakers talking about their experience so far. So you're all very welcome. Just to, let me just have to get my my slides working. I apologize. So just to be clear, the webinar is being recorded, available to members after 24 hours. All the participants are on mute. If you do have questions, please use the questions tab. Use the chat if you want to message the coordinator if you have any particular issues. But if you have questions for any of the presenters as we go through, please put them on the questions link. And then in the last 15 minutes, we'll have questions and answers and some discussion between us all around where we are with ICS. So just a little news update. We think we're on COVID number 15 webinar from the National Orthopedic Alliance. Happy birthday, 73rd birthday to us all, and congratulations to us all on our George's Medal. So Freedom Day coming on the 19th of July. We're still not absolutely sure what that's going to look like. And since last June, you can see we've had Matt Hancock is out because of an impropriety, and we've got Sajid Javid in. He seems very eager. He seems very keen to open up and get things moving again. And whether that's a good thing or a bad thing, we're not quite sure, because there is concern around the surge of Delta infection regionally and in the different countries of the UK. It is actually interfering, we understand, with some of the recovery plans in orthopedics, in particular around staffing. So we've heard from Bod's chat today that in one particular trust, 45% of the theatre staff are out because of isolation, mainly related to infection through their kids. So that's a big issue that hopefully will be resolved next week with some new rules. Yesterday was the second reading of the ICS bill in Parliament, and then it goes on to the committee stage. And then, as we explained last time, it hopefully will be into law in April 2022. We just get the feeling that everything is going to change between now and then, what it looks like. There's been various comments already in the last 24 hours from the BOA, from Health Foundation, from Nuffield Trust, Royal College of Nursing, concerns about the control that these new powers will have, so that the Secretary of State will have more control over the situation with the NHS provision, and whether that's a good thing or a bad thing. And certainly Jennifer Dixon from the Health Foundation does not think it's a good way forward. Also concerns from Nigel Edwards. But on the staffing issue, which is the big issue we seem to face moving forward, funding and staffing. So Pat Cullen from the RCN is also concerned about how this is going to be managed with the pledge of getting 50,000 more nurses into the NHS. So we've lots more to hear about this. I'm just going to back. So last month, just to clarify, we had Rob Hurd from London North Central, who's chair of the ICS down there, or the shadow ICS as we call them, and he gave us an insight into what's going on in London and the good things and bad things. And we also heard from Andrew Bennett, who he is a big player in the Musculoskeletal Alliance in terms of getting things moving in the pathways towards orthopedic care. In other words, that part of the pathway prior to our surgical intervention. So today I'd love to welcome Professor Peter Kay. He's got many hats on, but basically he's a budding hip and knee surgeon, and he's clinical director of Wrightington Hospital, ex-president of various different things, BOA, BHS, former clinical director of MSK. And I just asked him really just to share his opinion on life, where we're going forward with this ICS, and where the money's going to come from, and where is orthopedics going to sit, and where does secondary care sit, and how do we fight for our money from the ICS going forward. So I've asked him to share some of the things that are in his head. And then secondly, we'll move on to Leah Miller and Tom Bramwell from the British Medical Association. So there's been various statements about the ICS from the president of the BMA. And Leah and Tom are going to share some of the policies from the BMA, their concerns. And I just note that lots of things are changing and happening all the time. So these two people are quite busy in the BMA. So the second part will be them sharing their the BMA opinion with us. And then finally, the last 15 minutes or so, we will have questions and answers and some discussion. So what I'll do, Peter, if it's okay, I'm going to ask you to share your screen. I'll stop sharing now. And we go straight to Peter Kay. Thank you and welcome, Peter.
Hi, thank you very much indeed. So, can you see that?
Yeah, that's looking good, Peter. Well done. Thank you.
Okay, so I'm a clinical director of a larger orthopedic unit from point of view lower limb surgery, and really to sort of share some thoughts about where we're up to and what's actually happening. I work at Wrightington, Wigan and Lee Trust. We're part of Greater Manchester. And so in a way, we've sort of had a sort of an ICS type approach for quite some time with GM really. And but I want to look at where we are and where things are sitting at the moment. So the objective of my talk is really to just think about other backlogs. Actually, you know, we've had backlogs before and how we dealt with them. Just think about where surgery is done and does it really matter where it's done? Maybe if you're a patient, it doesn't. Maybe if you're trying to build something for the future, it does. And really, how do we want to come out of this at the end of the day? Do we want to be bigger, better, more resilient, more sustainable? Or could we end up just being exhausted, sweated the asset, broken the staff, and fragmented and outsourced a lot of the service? So yeah, I mean, MSK is important. I would say that once, having spent sort of 6 years as MSK lead from the point of view of NHS England, and it, you know, MSK really matters. And it's been a very large area of spend in the past, and often it's only sort of hit the headlines where money was concerned in a way, and it was actually about trying to manage demand, an awful expression of stopping people coming into the system. And I think because of that, because MSK is not quite as sexy as other areas, because old people limping about isn't that emotive, we can sort of get pushed back to the queue. And we've, even before COVID, that was happening all the time in many ways. But because of COVID, because of obviously making room for cancer, for general surgery, other emergencies, I think MSK has been pushed to the back of the queue massively. And the current figures are, you know, 92,000 patients are trauma and orthopedics on the waiting list now. And, you know, general surgery is, you know, half of that, less than half of that. Whereas in standard times, it's been much greater than that, which means that other specialities have been able to carry on doing work, and we've really been held back, and we've been continuing to be held back in a number of areas because it's not felt to be that important, not that crucial. People don't die of arthritis, perhaps. And of course, we do know that these sort of figures. So this is hip scores, you know, so people can be really bad with arthritic pain. You do an operation and you move them from that hump in the middle to the right-hand side of the slide. You can actually return people to normality, very effective surgery. I mean, it's interesting, I spent much of my time working for NHS England trying to convince the system that, you know, even hip replacement wasn't a procedure of low clinical value, which was ridiculous really with all the research in the area. But what we also know, that if you look at hip and knee replacement, the worse you are in the beginning, the worse you end up. In other words, the double whammy effect, that if you get people to wait longer in pain and disability, actually, when you finally get around to their operation, tragically, their operation, their end result is not as good as it might have been if we did it a bit earlier. And of course, we're making people wait longer, so we really are causing patient harm in this, that we aren't really enabling people to be as good as they might be. And of course, lots of publications recently, that actually from the health economists, that if you do scores, actually it's worse than death having hip arthritis because it's so intrusive. It's something that just doesn't go away despite many people falling into opiate silos. It's a real tragedy that needs to be addressed. Trying to see where we are. We look at these figures here. So this is every May over the last few years, starting from May 11. So there were quite a few people waiting more than a year in May 2011. This was coming out of the back of trying to achieve 18 weeks. And then we had a period that there were very few people waiting a year. And then, of course, it suddenly shot up this year. So we've had backlogs before, which have been addressed to some extent. Well, I think this is a really important slide on the left. What this shows is that actually, if you go back to 2008, the more people have been waiting, the waiting list has been going up for a long time, even before COVID struck. And I think it's really important that we don't let the politicians rewrite history here to say it's all down to COVID, because it's not all down to COVID. Because if you look at that graph, actually, COVID only has a little effect towards the end of it, but our waiting times, the number of people on the waiting list have been gradually going up from 2008 to the present time. Sure, made a lot worse with COVID, but it was a structural deficit that was there originally. And of course, if you look at the winter pressures, 2020, COVID wasn't the first time that elective surgery stopped. In the winter of 2018, all elective surgery was suspended for a month. And maybe that was a sort of telltale sign that the system was going to creak, if challenged, because we weren't even managing our elective surgery then. Okay, fine. So the number of hospital beds have fallen over the years, which, we can understand to some extent. We've had efficiencies and all the rest of it. But don't forget that the population has been getting much older. The comorbidities have been getting greater. And so we have been reducing the number of hospital beds and therefore putting more pressure on the system, sweating the asset maybe in what we've got. And if you look at as an international comparator, the UK at the bottom there, 2.5 beds per thousand of the population. But you look at something like Germany at the top with 8.5. And Germany is very interesting actually, because Germany was sort of a bit criticised perhaps over the years of maybe having too much over provision of healthcare, degree of redundant capacity. But gosh, when it came down to it and the systems were stressed with COVID, actually having a few extra ICU beds and a few more beds in the system maybe stood Germany, for instance, in good stead. And so we are quite low down in the number of beds that we have in the UK, and of course it's been falling relatively consistently over the last 15 to 20 years. Yeah, the length of stay is reduced over the last 20 years as well, as we would imagine it would do, as we've increased efficiency, as we brought in enhanced recovery type systems. So maybe the beds have gone. So the beds have gone down. The number of beds have gone down, but our length of stay has gone down. So maybe that should balance out. But if you look at the bed occupancy figures over the last 10 years on this graph, that's really climbed dramatically, and that's important really because it's been recognised that occupancies above 85% can be a real problem with trying to manage infection control, and that was sort of pre-COVID infection control, but also with the COVID as well around that. Occupancy is important, and we're now getting to sort of dangerous levels. So the system is really being stressed in terms of the capacity that we've got there. And of course, people have said things over the years like, well, maybe the NHS doesn't deserve any more money until it becomes more efficient. But the danger is if you make it so lean and so thin in its ability to cope, then of course, when it is stressed like we are now, then the wheels can start to come off. And of course, the whole discussion about social care, this graph shows that the people delayed in hospital, and very good that we've now got a big focus on social care and the fact that we need to drive that to get people out of hospital to free the beds. Now, obviously, at the end of the day, money does tend to be the thing that drives the system of where the money's placed. And if we look at tariff, the amount of money that each individual surgical case will attract, from about in relative terms, that has been gradually reduced over a period of time. And some of that's about efficiency factor, that's blue at the bottom. And of course, there's been pay inflation, etc. So the dark lines at the top. So relatively, tariff has not remunerated the hospital as well as it might have been. And it's only recently, over the last couple of years, that that's increased, that it looks better from the point of view of tariff. And of course, with ICSs coming, or the thought of the ICSs coming in the future, the idea that we've now moved on to block contracts, just at a point when we could see an easy way to get income into a hospital by just doing more work, with tariff funding that, we are losing tariff completely, going to block contracts. And it then becomes really quite difficult to understand what is the pathway to drive efficiency and do more work if it's not funding cost per case. And of course, the whole thrust of ICS is, of course, of reducing or getting rid of competition between units is another factor. Now, obviously, we've got efficiencies, and I've been involved in this for years, whether it was the orthopedic project initially, the musculoskeletal services framework, the whole 18-week work at around 18 weeks. And of course, we've now got GIRFT as well. So we've had 20, 30 years or more of increased efficiency, which undoubtedly have made us more efficient and dealt with things better. But perhaps, and I would argue that maybe increased efficiency isn't going to be the whole answer to this moving forward. It's not just about trying to do more with what we've got. We need a little bit more of what we've got to deliver that. And yeah, we've got NHS plans that have come and gone over the years and want to deliver some very important points in terms of patient choice, funding for actual outcomes rather than just volume, how we focus what we do. And a lot of some of those aspirations are perhaps getting a little bit swept away at the moment as we're looking at some fairly draconian ways of how we might manage backlog, etc., about being quite prescriptive in what we might offer in terms of services and where services might be located. So getting it right first time is, focusing on the idea that we want to have a shift away from competition towards collaboration and partnership and integration. And BMA will be talking about the integrated care system, or how that might look like, about improving efficiency, eliminating inequality, but recognizing that there isn't a one-size-fits-all approach. It is different in different areas. And but by transforming care, we should be able to shift some of the backlog and get more work done. So we're trying to develop good care. I mean, good care should sort of transcend really the contractual arrangements that underpin it. And it's not primary care and secondary care in isolation. It's working together. We do need to deliver what we do with a team. We need to integrate the care across all providers, the carers, employers, the whole playing field really of what's out there. And we need to deliver care in the appropriate specialist settings, sometimes specialist hospitals, sometimes near a home. And hopefully that, we are trying to address the needs of the patient rather than the system. So getting it right first time talks about transformation, looking at high volume, low complexity surgery program, as well as day case surgery. And the issue about it is, I think it's important, is that yes, I think we can go so far with being efficient with what we've got, but perhaps we do need more infrastructure because of the fact that we clearly have a structural deficit, the fact that waiting times and pressures on the system have been really climbing since 2008, not just from the start of COVID. And lots of examples. And of course, we had the seminar from a few weeks ago with Rob Hurd talking about North London partners, etc., what's happening in North London. Examples from Devon, from my own areas, from around Lancashire and Cumbria, about how we might be modernising, transforming the system to cope with the pressures of what we've got. Yeah, I mean, it's easy to say things like, work smarter, not harder, but gosh, we do have to work pretty hard at the moment, and it's only going to get worse. From the College of Surgeons, I'll come on to that. Lots of support from the idea of innovation and collaboration, creation of surgical hubs and mutual aid, and obviously working closely with general practice. if we look at orthopedics compared with other specialities, and so the red bits are pre-COVID, the blue bits are post-COVID. Actually, trauma and orthopedics, as I said before, has taken the largest hit, whereas a lot of other things have actually carried on delivering quite a lot of activity. Finished patient episodes like neurology and thoracic medicine haven't really changed much at all, and other areas such as dermatology and oral surgery, yeah, it's been affected to some extent, but it has continued. And there's that big worry, of course, that within all of this, that the number of patients actually going on to the system has sort of also fallen off a cliff as well. So far fewer referrals. And of course, that was heralded at one point by Simon Stevens saying, well, it's not that bad because, I mean, we are able to produce, address the activity, but of course the activity was seemingly quite low at that point. But as we all can now see, there's an awful lot of people coming out of the woodwork now, whether it's not just attending A&E departments, but people with elective orthopedic conditions that have been maybe too frightened to go to hospital, or felt they were doing the hospital system a favour by not cluttering it all up because of managing with COVID, but now they really need their treatment because they're in a very bad way indeed. And if you stand back and look at the waiting list, again, this is pre-COVID in red and post-COVID time in blue, the overall shape's not really changed. We put less people on the waiting list in the early parts of COVID, and we've got some bigger long waiting list, waiters at the moment. But actually, the overall shape of what's been going on has always been there. So the problem has existed for a long time. And so look at like the Health Foundation, they really are asking, the government really needs to address this long-standing underinvestment in the system as this backlog grows. And really we have to address not just the backlog we've got, but the issues behind not having the capacity to deliver what we really needed to previously. And so the College of Surgeons have looked at this, and they've come up with a new deal of surgery that's published about 3 weeks ago, and made a number of points which are important about making sure that the government make it clear that it's transparent in terms of the data describing what's in place, looking at the possible role of the integrated care service, moving it forward, increasing the number of beds, and building NHS capacity to reduce our reliance on the independent sector if we see further problems in the future. And those problems have been there even with winter pressures beforehand. Looking at the idea that if COVID's going to be with us for a long time, then we need sort of COVID light sites, and the idea of the surgical hub model where people may travel a distance to have their intervention. And we certainly need to look at staffing, both not just nursing staffing, but also surgical staffing as well, that needs to be increased. And the whole workforce problems that sit in the background here, as we all find it difficult to get staff as we try to increase our activity. And the surveys that have been done with the College of Surgeons asking patients, I mean, many patients are willing to travel to more remote locations, away from their local hospital to surgical hubs if that's where the activity is going to be, and the idea that we may need to fund and develop these hubs. When we look at the independent sector, there is actually real significant instability there. We've seen Spire has recently been bought out, by another provider, and we've got in Bath, the NHS has bought some hospitals from Circle, and there's a degree of volatility, I think, within the private sector at the moment. And yeah, it looks like there's a great opportunities for the private sector to cash in and do the work, but I don't think the private sector has its own problems, and I'll come on to that a little bit. So if we look at where the money is at the moment now about elective care, as we try to sort of address the backlog, and this has been dealt with at a system level. This is even before ICSs have started to exist, but basically at local system levels, that yes, if a whole system could deliver 70% of its activity in April, 75 in May, now 80, now 85% of activity, the whole system can get extra money into the system. So if we look at Greater Manchester, that's a sort of promise of money to a whole host of separate providers. but there's no clear route to how that money gets to an individual provider and how that money might be divvied up across the system. So when we talk about getting paid 120% of tariff if you hit particular targets, which sounds impressive, there is then no particular way that an individual provider understands how it can access that money. So from the point of view of, say, my own hospital, there's a degree of nervousness about spending more money on putting in another modular theatre, say, or employing more staff, because we will only see the money after the activity has been hit. And actually, if the payments are going to be made to the whole system across several providers, you could take the view of one provider might say, well, I'm not interested in putting any resource into this because if the rest of the system performs well, we're going to get the money anyway. And then another provider may say, well, actually, hang on a minute. Am I really going to, I'm putting a lot of money in here. Am I really going to see a return on this investment if the rest of my colleagues, my other providers, let me down and we hit the overall target? So real questions which produces a degree of nervousness in the system, that it's not as clear as it used to be, as in cost per case, that if you did the case, you would get paid, and you could provide a very simple business case that would describe that. And you knew that an investment could be eventually paid for. And of course, there is the legal responsibility for these organisations to balance the books. So what worries me about this, I think it really matters where the NHS spends its money. And we really need much better clarity, I think, about the funding mechanism and the flows of money to the sharp end, to the individual units. I think there's this idea that relying on the independent sector will be the answer to everything, but it's not the answer to everything, because A, it's not that large in terms of the independent sector to actually start to tackle the enormity of the backlog, but the independent sector creates massive unintended consequences. It produces planning blight that a manager might say, well, gosh, if the independent sector are going to take a lot of this work, why do I need to invest in my own unit? We are actually competing for the same staff. And I'm seeing it already in my own hospital. I'm clinical director, that consultants are less available now because they may be working in the independent sector more of the time than they were before. And therefore, if we have extra lists to be run, maybe we haven't got the staff to staff them. And of course, the nursing staff as well are being offered extra hours, extra money to work in the independent sector. So some of our own staff are disappearing out of the NHS. And there's this sort of idea that if you rest the NHS, it'll be somehow become more efficient. That if the independent sector takes the strain and allows the NHS to recover a bit, then at some point in the future, the NHS will be fit and ready to take over the mantle of providing the capacity. But that's just not true, because if the NHS doesn't do the work, it can't get fitter, it can't get more efficient. And so it's a fallacy to assume that the independent sector will improve the rump of the existing NHS. It's more likely to perhaps undermine it in terms of staff and simpler cases moving into the independent sector. And of course, the whole training and quality issues. So yeah, I think, what we want to see coming out of this is a bigger and a better and a more resilient NHS. But it's really not clear at the moment how these large pots of money that seem to be there to address the backlog really going to find their way to the front end to allow us to open the capacity that we've got, if not, and increase the capacity that we've got to deal with this. So when I attend the meetings as clinical director in Greater Manchester, I'm stuck between getting involved in a discussion with what effectively is an ICS. I've got great plans to take things forward, but going back to my own trust and saying, well, are you happy to put resource into more staffing? Can we recruit above complement? Can we open that extra theatre? And the answer that comes back is, well, we can't really do that just at the moment, because it's not really clear how we're going to get funded. And that, I think, is one of the main problems that we've got at the moment. We are increasing our activity, but we're increasing it at risk. And there isn't a great risk appetite within finance, I think, to go too far in increasing the capacity, unless we can really see a simple pathway to get the money to the front end, which I think the system is lacking at the moment, and we need more guidance from the centre of how we can achieve that. Thank you very much.
That's great. Thank you, Peter. Just to illustrate a point, we appointed an outpatient band 4 nurse who was supposed to start last week, and she's decided to go with the vaccination hub because there's more money there. So we are competing with each other for these jobs, and where the staff is going to come from, I think, is a real issue. Retaining staff and where all the new staff are going to come. So where are these 50,000 nurses going to come from? Thanks, Peter. I'm sure there'll be more questions as we go through the afternoon. So once again, I'd like to introduce Leah and Tom from the British Medical Association. So I'll go straight to you, Leah and Tom, and if you'd like to share your screen. Thank you.
Thank you. Hopefully you should be able to see that now.
Yeah, Tom, that's great. Yeah,
perfect. Well, thank you. Yeah, so my name's Tom Bramwell. I'm a senior policy advisor at the BMA, and I'm the policy lead for the association on system transformation, so ICSs, and the policy aspects of the health and care bill, working alongside Leah in our public affairs team. So we're going to run you through some of the kind of key content of the bill, particularly in the kind of in our mindset and our view of it, as well as what that means in our view for secondary care doctors in particular, and how we're approaching, you know, its passage through Parliament, and kind of what our key priorities, concerns, and you know, focus points are really. So looking at the bill kind of at a glance, and this is off the back of Leah and I having kind of rapidly read through it in the last day or so. Essentially, I think one of the key characterizations of it is that it's a significant reform of the 2012 Act, with quite a lot of the aspects of that bill either being stripped out or kind of subverted formally now. But I think some of the press coverage around this has sort of indicated that the new structures, so namely ICSs, are a new thing, and I think it's quite important to reiterate that they're not really new, and I'm sure many of you have kind of worked with or been aware of your ICS for a few years now, and before that STPs when they were in that kind of format. So really I think what this is in the sense of ICSs at least is a kind of confirmation of their role, and formalizing that kind of duty, or the duties that they have, and kind of them taking on CCG duties, particularly around commissioning. Also kind of in terms of the competition aspect, so section 75 will be removed, ending mandated competitive tendering, which we'll kind of touch on in a bit more detail in a second. And also within ICSs, and more generally, all NHS bodies are going to be given a duty to collaborate, and also kind of the triple aim, and that's one thing that's really kind of borne out in the bill, is the kind of the duty to adhere to a triple aim of better care for patients, the kind of the health of the local population, and sustainable use of NHS resources. And that's kind of very much been applied to the ICS, the kind of relevant bodies within that, and also NHS trusts more widely. In addition to that, and kind of I suppose the most controversial aspect of the bill is the greater powers and limited additional accountability for the Secretary of State. That's controversial not only externally, but also apparently within the government as well. So that's something we're kind of keeping a close eye on. In terms of kind of structures, so ICS is obviously the big element of that. And as I said, they'll become statutory bodies, which formalises their role and importantly their accountability for the planning and provision of care. We've been very critical in the past of the fact that ICSs and STPs again before them have been informal bodies and therefore not especially accountable. So, you know, in that sense, it's a kind of forward step, but obviously we have to see how it works in practice. So ICSs will be formed of two kind of key parts. So the Integrated Care Body, or ICB, which in the white paper and other documents has been referred to as the ICS NHS body. So that will focus primarily on core NHS services. So that will take on the commissioning responsibilities of CCGs, particularly in terms of kind of the management of funding as well, and directing where funding goes, including capital funding, as well as the vast majority of CCG staff. and existing contracts that they have as well. Alongside that, there'll be the Integrated Care Partnership, or ICP, which is very unfortunate terminology, given that that acronym has been used for quite a few different things in the last few years. This was previously referred to as the ICS Partnership, or ICS Health and Care Partnership. That's focused on wider issues, essentially, so public health, social care, wider things even than that, so housing, education, employment. The idea being that that's kind of where the wider strategy will be set for the ICS, or at least kind of where the core development will go on, taking that kind of broader view of well-being and care, and looking at prevention as well. So that's obviously very important. In terms of membership of those bodies, there's been kind of very limited guidance. The legislation really doesn't include much on that, bar the kind of setting the core standards, which NHS England had already sort of proposed themselves in terms of having a chair, a chief executive, and for the for the integrated care body, having a kind of core 3 members, 1 from local authorities, 1 from primary care, and 1 from trusts, who is likely to be a manager. And then beyond that, there's kind of some wider requirements, but it's really kind of up to local systems to decide who sits on those boards, with the approval of NHS England and in respective chairs, the Secretary of State. Again, you know, the bodies will be bound together by the duty to collaborate and a triple aim, intended basically to kind of push that idea of collaboration, so that individual units are genuinely working together. Well, the legislation wants units to genuinely work together. Again, obviously, it has to be seen how that operates in practice. One of the major changes, and certainly something that's kind of been particularly kind of high profile within our membership, is the changes to competition and commissioning. So Section 75 of the 2012 Act will be removed, which in essence will remove the present requirement for commissioners to automatically put contracts above a certain value, which I think is £650,000 out to competitive tender. So the replacement would give commissioners three options really instead of that. So the first one would be to renew contracts with existing providers without tendering. A second would be to offer new or existing contracts to providers without tendering. So whether you had a brand new contract or you wanted to award an existing contract to a different provider. And the final one, to launch a competitive tendering process for contracts where that's deemed appropriate. The kind of mantra behind this is that it would see less wasteful competition and greater stability, which is something we've argued for in the past, and BMA and others have been very vocal about the damage that Section 75 has done, and they need to remove it. However, our concern is that, and I know it's shared by others as well, that simply removing the kind of automatic tendering element of Section 75 isn't really enough to put proper safeguards in place to prevent the risk of greater fragmentation that can come with unnecessary private sector involvement, mainly because it could, in theory at the very least, see contracts handed to private sector providers without proper scrutiny, or the kind of transparency that does actually come with the existing tendering process. And I think one of the main drivers of that concern is obviously some of the contracting we've seen during the pandemic, and from government to PPE suppliers, and, you know, test and trace. So there's definitely an anxiety around that. In our view, and this is something we'll kind of talk about later as well, but the best way of kind of introducing a safeguard into that is to make the NHS the default option or preferred provider for NHS contracts. So that essentially it's you know, NHS first, and if they're not able or willing to provide a service, then it can go out to tender, or we look, you know, other kind of considerations can be brought in then, and that's our kind of our ultimate view on that particular issue. More widely than that, again, there's a kind of the high profile points around power and accountability. So in essence, the bill would kind of give the Secretary of State new powers around setting or resetting the direction of the NHS outside of the current annual mandate system. So that opens up the possibility of more political interference within NHS England's kind of aims and what it's working on, particularly if there are any rapid changes to kind of political priorities, such as the change in the Secretary of State. In addition to that, there's a possibility to amend and abolish arm's length bodies. Looking through the actual bill itself, there's some limits to this, but it still is fairly significant that the Secretary of State would be able to kind of fairly rapidly amend or change the duties and responsibilities of individual ALBs, including NHS England. Though there is a caveat that they wouldn't be able to make NHS England redundant in their view, which is obviously fairly vague. So something we'll kind of push on to get a bit more clarity. But that's obviously caused quite a bit of concern, and rightly so. It would also allow Secretary of State to create new trusts and approve kind of trust reconfigurations more rapidly. So if that's trust splitting duties or kind of moving apart, this mainly relates to the integrated care provider contract as far as we see it, in terms of making that an easier process to deliver. But it's obviously something we're keeping a close eye on. Also, it would strengthen the powers of the Secretary of State to intervene in service reconfiguration. So where a trust or a ICS is looking to kind of change the way services are structured, the Secretary of State could intervene more kind of proactively than they can currently, and essentially kind of either reverse or dictate to the body in question how they kind of pursue that ultimate decision. So there's been some kind of fairly strong concern around that, particularly from NHS Confed, I think, and providers, around the possibility of that leading to political decisions on potential reconfigurations rather than ones based on evidence. I mean, I think it's a bit of a mixed bag in that sense, but it is difficult to see how a Secretary of State would be very reluctant to why they would be most likely to support their local political colleagues in a way, in terms of if there was a dispute around the change to a hospital or any kind of reconfiguration like that. So we'll have to see how that one pans out. But I think there is kind of very understandable concern about how that would work in practice. And there's also new powers over data collection and storage, which I think, given the wider concerns around data at the moment, have caused some concern, and we're looking at again very closely. The final one is more of a duty, one of the few duties applied to the Secretary of State, but it's basically requires them to publish a report or set out once every 5 years, so every Parliament, the system for assessing workforce numbers and requirements for the NHS. We've been very clear that we want that to go much further, and I think a lot of other stakeholders and kind of unions are on the same page, like the RCN, for example, very much on the same page in terms of that being a stronger requirement, more around sort of full assessments and taking genuine political responsibility for workforce numbers. So in terms of key implications for secondary care, this is quite broad. So obviously, I'm very keen to hear what you all think and what you see, particularly in relation to kind of orthopedics, what the priorities would be, or where you see there being kind of potential issues. But the first thing, and this applies to all forms of all branches of practice, all forms of kind of medical care, but the clinical voice. So I think it's absolutely essential that ICSs embed clinical leadership, representation and engagement. And I think we've seen those things as different elements at all levels. So that includes formal roles for secondary care clinicians and for LNCs in our mind. I think obviously one of the notable changes with CCGs is that the kind of GP voice, which has been very prominent in them, it risks some kind of diminishment as they move to ICSs. But obviously the secondary care voice within CCGs has been a long-standing issue, and not been as strong as certainly as we believe it should be. So again, it's kind of even more important that we have proper kind of routes and options for there to be a strong secondary care doctor voice in ICSs to kind of ensure that decisions are being made in the kind of most appropriate way. In terms of commissioning, as I said, ICSs will take on responsibility for commissioning of most NHS services from CCGs. That includes secondary care, as well as primary care and a range of different aspects of service commissioning. In terms of funding, ICSs are going to be responsible for distributing resources, including capital funding, within their footprints. I think that the way in which that's done is going to be left, I think, fairly broadly to ICSs themselves, but NHS England will be able to kind of put clear requirements on how certain funding should be used and where it should go. But that just, I think, again, emphasises the importance of having a strong kind of clinical voice there to make sure that funding is going to the right places. Also in terms of integration, so services are going to be expected to collaborate more closely, particularly trusts. There's a big focus on things called provider collaboratives, where trusts are kind of collaborating together with other organisations on particular issues and particular areas. So there's a big focus on, for example, mental health provider collaboratives at the moment, but that's expected to expand to kind of all other services. So given the specialty in question here, it might be that there'll be kind of provider collaboratives focused on that. That could either exist within a single ICS or kind of straddle more. So that's quite an important development. And generally that focus on looking beyond the boundaries of an individual trust and kind of seeing how it works as part of a wider system. So that could just mean generally either breaking down of boundaries or kind of a greater kind of greater involvement of other services in the care that's delivered and planned by a particular trust. As well as that is reconfiguration, so linking back to the kind of Secretary of State powers in a way. ICSs might look to change how services are provided currently as they take that kind of system-wide view of things. We've seen this happen with stroke care, for example, and looking at concentrating specialties in certain sites within their patch. Some of those changes have been quite controversial, I think, but it's possible that will extend to other specialties as well. So ICSs may look to kind of focus provision within specific sites of non-urgent care, at least, in the kind of interest, I suppose, of economy or safety. But that's something to certainly be aware of and kind of monitor. And I think it's important to kind of keep an eye on what ICSs locally are doing around that kind of thing. And also the kind of final point, but I think quite an important one, is ways of working and kind of where people work. So staff are generally, it's likely to be expected to work across a wider area potentially. So rather than contracts certainly in the future being bound to individual sites, we might see this kind of move towards a greater sense of system-wide working. That doesn't necessarily mean people are going to have to travel, all the way across the footprint, but more that idea of people not being kind of tied directly to a single site, but maybe working across multiple sites or in different areas, which obviously some people already do, but I think it's this kind of idea of that being expanded a bit more. ICSs, for example, are looking at things like passporting, and there's been digital staff passports, particularly in response to COVID, that have been introduced, which would really kind of give you a sort of act as a means of allowing staff to go to different sites and work without kind of going through a significant amount of paperwork, is the idea behind that. As well as that, there's also kind of a focus on some specialties, particularly kind of working more in the community than they do already. And that particularly, I think, ties to the kind of prevention agenda too. I think this is the last slide for me, and I'll pass on to Leah. But in terms of kind of positive signs of the bill and of the kind of white paper before it and NHS England's proposals, I think we've been very clear for a long time that we believe that the NHS should be more collaborative. The BMA's Caring Supportive Collaborative report, for example, really focused on this, and that kind of needs to move past the sort of siloing that's been put in place, since 2012 and before that even. As part of that, we've kind of been supportive of previously the removal of Section 75 and the end to enforce competitive tendering, though obviously, as I said, we're very clear that there needs to be further safeguards to that. As well, putting ICSs on statutory footing, which should ensure proper accountability and transparency around what they're doing, which has been definitely lacking to date. There's been some moves towards regulation of NHS managers as well, which is something we've been supportive of. And generally, I think this was touched on in Peter's presentation as well, but that kind of move away from present payment models and kind of payment by results to things like block contracting, and kind of just shifting away from the kind of churn in that sense. But yeah, I'll pass on to Leah now for the rest of the slides that we have.
Thanks, Tom. So I'm just going to go over our kind of key concerns and campaign priorities. Tom's already touched on many of them, but just to kind of give a summary really of the key things that we're going to be focusing on over the next few months. So there will of course be numerous things within the bill that we will want to comment on and intervene in, but in terms of our kind of top priorities, a really key thing for us is protecting the NHS from unnecessary privatisation. We've seen the impact of this in terms of costly procurement processes and fragmented care, and we know that it's something that our members are concerned about in terms of the way that it impacts the quality of care delivered in their local areas. So we've been very clear that whilst we welcome the removal of Section 75, and it's something that we have called for since the 2012 Act, we need to make sure that the provider regime that replaces it ensures there's sufficient scrutiny and transparency of the awarding of contracts. So I think, as Tom kind of mentioned earlier, we would be very concerned if we ended up in a situation where contracts were being tendered out without sufficient scrutiny and transparency. And as we've seen during the pandemic, where this has been the case, it's had a big impact on the kind of delivery of care and services. So ultimately, our key call in this area is to establish the NHS as the default option for delivering NHS services. So that would mean that the private sector would only be commissioned to provide services where it was absolutely necessary and there was a good reason. So that would be our kind of key call in relation to that. Another critical area for us is ensuring that there's meaningful clinical leadership and representation, and that's the case throughout every level of ICSs. So it's not just concentrated on ICS boards, and it's not just concentrated at managerial level, but actually is true kind of clinical representation. So we've called for a formalised role for LMCs, LNCs and public health doctors within ICSs to help achieve that. Another key area for us, and something that's been, I think, mentioned by both Peter and Tom, is the importance of making sure there's accountability in terms of workforce delivery. So whilst the bill does contain a duty for the Secretary of State to report once every 5 years on the system in place for assessing and planning workforce needs, we would want to see that strengthened with a commitment to actually assess what needs to be delivered and set that out so that we can adequately hold the Secretary of State to account for then delivering the staff that's needed to meet demands now, but also into the future. And that's something that we've been working with various different stakeholders on calling for. And then finally, another critical area for us is around the new proposed powers for the Secretary of State. We're very clear that we wouldn't want to see any kind of undue politicization of the NHS and NHS policy setting, and it does appear to us that the bill as proposed at the moment, really the changes seem to be much more geared towards delivering new powers for the Secretary of State rather than that accountability. So we would want to see adequate safeguards in place over where they should be used, and the system in place for ensuring that there's parliamentary scrutiny and accountability over the use of those powers. So finally, just moving on to the next steps in relation to our work on the bill. As mentioned, a lot of our kind of lobbying around the bill is already underway. We've been, over the last few months, holding various different meetings with government ministers and DHSC, NHSE, as well as feeding into consultations around the provider regime and the ICS design framework that will kind of sit alongside the bill. So the government intention is to implement the bill from April 2022. Obviously, that means that the bill will have to progress at quite a pace to be in a situation where that's possible. We obviously do now have the bill that was published yesterday, and we're expecting second reading next week. And then the current understanding is that committee stage, so the stage where amendments will start to be brought to the bill, will take place after parliamentary recess, so around September time. So we will continue to lobby politicians on our key priority areas and aims by briefing into the stages of the bill, as well as continuing to work with other stakeholders and identify parliamentarians who we can work together with to really press on delivering the changes that we need to see. Alongside that, we'll also make sure that we're keeping our members up to date with all of the work that we're doing as it progresses, and that includes making sure that we're then reflecting the concerns and priorities that they're kind of feeding back to us as the bill progresses to parliamentarians, and making sure that we're acting as a route for doctors to get their voices heard throughout the progress of the bill. So I think that's about it from me. Thank you very much for listening to us.
That's great. Thank you very much, Tom and Leah. Lots of questions. We probably could do another part 3 after all of this, but I've just been informed that Amanda Gaston, who is Deputy Finance Director of the Royal Orthopaedic Hospital, might be around to just add a comment. So Amanda, are you with us?
Yeah, I'm here. Can you hear me?
Thank you for joining. I can hear you. Yeah. And any comments, because we are interested very much in the money end of things, and just wondering where are things from your end at the moment?
Okay, so kind of wanted to start with, let's not forget where we've come from in orthopaedics. So we've been quite used to having to fight our corner for appropriate funding, and the change to tariff a few years ago disproportionately impacted upon us as an orthopaedic specialist trust, and we had to do a lot of work in the background about making sure that we'd got a sustainable and financially suitable envelope in which we could work with. So we've been quite used to having to fight our corner with orthopaedics, and I think it doesn't look like the landscape is going to change anytime soon around that, and we need to ensure that we're using our networks and using the NOA and the people surrounding ourselves with those networks that will support us to make that case. I think there's a huge opportunity for us as we move into integrated care systems for us to shape and mould those financial governance frameworks for us to ensure that it does meet the needs for orthopaedic care going forward, and making sure that as we move out of a system which didn't kind of help us previously, that we kind of learn from what we've done in the past and that history, and kind of build upon that. So within our integrated care system in Birmingham, we're very much having the conversations around moving towards a cost reimbursement model. So how do we set up the financial models and frameworks and such that it reimburses the right pathways in the right places? But it's a bit like an oil tanker. It's not going to change overnight, and it's going to be longer term change. So the short term kind of funding mechanism around the use of elective recovery funds has been something that we've been working on, and we've been having discussions with NHSI within the Birmingham patch around how at the moment that doesn't seem to be supporting us to be making the right clinical decisions and setting up services in the right way. From a funding perspective, it's not necessarily incentivising us to do the right thing. So how do we have that conversation then around what can support us and do the right thing for us? So we are we're having those conversations across the ICS, but it's not an easy question to answer, I suppose, and I think it's going to be how do we develop those longer term financial governance structures within ICSs so that we don't get forgotten as an orthopaedic service.
Thanks, Amanda. Just very briefly, just on a more practical issue. So your clinical director comes to you today and said, we need an extra theatre. I need 2 million quid to build an extra theatre or to drop one in. Tell me about how that's working out now and what might happen in the future. So I understand the plans for long-term planning around finances of secondary care. But what about now when we need an extra theatre to try and cope with the backlog? What happens now?
Yeah, and that's exactly the scenario that we're in at the moment, is those cases for how do we reduce our orthopaedic backlog at a greater rate than what we are doing in Birmingham. So we know that we're not doing enough quick enough, and we need more capacity to be able to do that.
Yes?
So
is that a yes or no?
Yeah,
so what happens when that request comes in?
So at the moment we're building a business case that says we need more capacity in orthopaedics, and that's going into an investment committee in the ICS to say that we need that money now, and we need to do something about it. So we can't forget the financial governance structures that need to be in place. The difficulty we've got is that there isn't an established financial governance structure within the ICS to cope with this kind of decision making. So we're going to the ICS to say we need more funding because we've got a capacity problem.
So
where does that decision?
Yeah, I'm hearing, sorry to interrupt, but I'm just hearing that it is a problem. It is a problem now.
Yeah, absolutely. And we're thinking about what are the funding models that we can do. Can we access them short term, additional capacity rather than committing to a long term? So we're looking at, you talked about the change of ICS, independent sector providers, and what their landscape looks like. So we're looking at, can we be a bit more creative with how what our options are about expanding capacity rather than committing to a fixed cost of putting in new theatres. So this is something that we can do that fits with the financial governance funding framework that we've got now. So there's some short-term options around, let's use some more of the independent sector.
That's great. Thank you very much, Amanda. I'm just going to go to questions now. So we've got 13 minutes left. There is a lot of questions, and I might, with your permission, I might skip through some that maybe have been answered already. So we'll just kick off with the first one. Can we afford the NHS that we all want? Are we heading for some sort of compulsory insurance as seen in other countries in Europe? Maybe can we start with our BMA people? Tom, maybe you might want to try and answer that one.
Sure, I'll do my best. I think obviously we've been really clear that the NHS needs to be funded better and kind of more comprehensively for a long time, and we've been clear as well that the funding settlements that we have had have been insufficient. I think some of that's been seen in the response to the COVID pandemic in particular, and the kind of need to really ramp up resourcing to ensure proper capacity in response to that. So I mean that's our position. I think we've been fairly clear as well in terms of the ideals of kind of integration and ICSs, that will hinge in large part on them being properly resourced in order to achieve what they're being asked to do. That's the same of PCNs as well in primary care and kind of all of these other functions that ultimately it needs to be backed up with proper funding.
So it's about more money from the taxpayer to fund all this, rather than looking at different ways of funding individual care, as is done in the rest of Europe? Or is there an opinion on that within the BMA?
I think the ultimate view is that the government needs to fund the NHS properly. Is our ultimate view.
While I have you there, Tom, there's another one here. What are the top concerns of doctors in the BMA about the future? What are they saying to you? What's their top number one concern?
I would say a combination, in more generally, a combination of pay and workforce. As always, I think, probably, at least in respect to pay and pensions as part of that. But workforce is a huge issue, obviously, is ensuring we have the proper number of doctors to be able to actually provide the care in question. There's a staffing report that's being published very soon by the BMA, which really covers this. And those issues, essentially, there being so many gaps in staffing at the moment, which COVID may only make worse given the amount of people that are looking towards retirement and early retirement. So that's going to be a major big concern, I think. In terms of ICSs, I think the biggest concern is making sure that they're kind of publicly run, publicly provided services that really have kind of patient care and well-being at the kind of heart of them, really.
Thanks for that. There's one here, Peter, that you're the only one to answer, I think. The situation Greater Manchester that looks like an ICS but has been around for a long time, and my understanding is essentially an ICS, so probably nothing much is going to happen in your region. Is that a fair assumption?
Well, it's probably, I mean, I suppose Greater Manchester was sort of very much a forerunner of what ICSs are going to look like, but the problem I think within Greater Manchester is that it hadn't gone as far as it would like to have gone so far. And I think that's just really an indication that it takes quite a long time to change healthcare systems that are in place. And okay, we've got legislation now coming for ICSs, which will obviously help support that moving forward. You could argue that one of the problems that GM had was because there wasn't legislation to try to do the things it wanted to do early on, made it very difficult for it to do. So, you know, I think Greater Manchester was going along the road of trying to achieve something, but it wasn't quite there yet. And there'll be just more of that, I think, moving forward.
Thank you. Just back to the BMA, somebody mentioned, I think it may be Tom, I think. One of the things is more regulation of NHS managers. I see a question here. Why do we need regulation of NHS managers?
Yeah, so that's been a kind of long-standing, I think, issue amongst our membership and something that's been borne out in previous kind of all member surveys. I generally think it's down to the fact that clinicians often feel they're being held responsible through their own regulation for things that ultimately kind of lead back to decisions made by managers. So whether that's kind of pressure on them to deliver X amount of care with X amount of staff, as we've seen can often lead to quite challenging situations. That's my best understanding of where it comes from, but that's kind of been a long-standing issue generally, I think, about the sense of unaccountability for some NHS managers.
Okay, thanks for that. Next one is a general question. Yeah, where do we get the staff from? Even if we have the money, the pay is not good enough, and 1% won't make a difference to me. I'm presuming this is from one of our nurses. So does anybody want to take that up? Where do we get the staff from? Anybody, any ideas? No takers on that one. I think I understand why.
I can come in briefly on this, Cormac, if helpful.
Yeah, thank you, Leah.
I think just to say that I think that question in itself exposes a huge problem that we have in the NHS at the moment. We've long had workforce shortages, as Tom said. It looks like COVID is only going to make that worse. Staff are being faced with undue pressures with the kind of COVID backlog that they're having to meet. And meanwhile, the government isn't matching that with the kind of pay increases that we need to see within the NHS. So I think, you know, it's not a simple answer, but I think the government really needs to start valuing NHS staff better. And a way to do that is obviously giving staff the kind of remuneration that they deserve, as well as looking at how to improve well-being throughout the NHS. We're also sort of simultaneously in a position where freedom of movement has ended under the new immigration system. Whilst obviously there's a route through the NHS visa into the NHS for some NHS staff that doesn't include, you know, certainly social care staff, and I think that's another area where we're potentially looking at a big kind of impact on the wider delivery of health and social care services. So not an easy thing to address, but I think, you know, government really needs to start valuing staff better, and the first area they could begin is by delivering a pay increase.
So lots more money for everybody, lots more money in investment, lots more money, lots more money. Who's going to pay for it all? Interesting question. I think that the general feeling in the ICS is that we want to maintain the NHS at all costs, but it's not clear where the money is going to come from. Will there be that big increase? Will there be an NHS tax? So the last question, I'm going to leave it at the last question, if that's okay with everybody, which is an interesting one. There's been a big increase recently in self-pay patients. Is this good or bad? So we're finding that a lot of patients who are on one waiting list, they seem to be coming to the private sector, but also to NHS hospitals asking for private care, funded by themselves if they're wealthy, but more often by their families. So it doesn't make one feel very comfortable. I'm just wondering, has anybody got an opinion on this? Maybe back to Peter again. How do you feel about that? They come knocking on your door in the private hospital, shaking a load of cash at you. With your socialist views, Peter, how does that go down?
Well, I don't work in any of the private hospitals as such, though at Wrightington, where I work, does have a private ward. So we do undertake private work within the hospital. Obviously, there are great dangers of the conflicts of interest in terms of waiting times, about how that can work, and the big problem that we've had, of course, is we actually haven't got enough we've not got enough NHS capacity. We haven't got enough private capacity to manage the demand. I think it is tragic when people are spending the family silver or whatever on care because the NHS can't provide it. Maybe it doesn't. We were talking about other examples of healthcare systems around the world, like France, for example, where we have a sort of mixed economy of it. Is that good or is it bad? I'm not sure. I do have socialist views. I would like to see enough capacity and space in the NHS to be able to manage that. I think if people want to pay for their own private care just as much as people can make decisions about whether they want to drink alcohol or smoke or do whatever, people can spend the money how they might like to. But I think at the moment, I think it's really not great that we are effectively forcing a lot of people into the private sector for their care. And I just feel, and that's what I alluded to in what I said, that can create planning blight effectively within the existing NHS. And just to the previous point that's made about money, absolutely. I think if you value staff, you can value staff by paying people more, and that's okay. I get that. But I'm not sure that's the answer, moving forward about staffing. I think it's about having sustainable systems, sustainable NHS units where people can have stable employment. And I think there are a lot of people out there that will come out of the woodwork to work on those systems, whether it's retired people or whether it's people that are working other places. I don't believe it's purely about money and competing with McDonald's or Amazon. I think it's about creating systems that people enjoy working in, that they feel they're contributing to, that feel that it's making a difference.
Okay, thanks for that, Peter. And just final word to Tom and Leah. Do you want to say anything? Do you want to comment on self-pay? Any opinions from the BMA on that, or does that come into the equation at all?
I think, regardless of whether it's good or bad, I think it's understandable for some patients, given the extent of the waiting list and how bad that's got and the backlog in care. We can understand why people would look to do that. So I think, as Peter said, our ideal and what we've pushed for is that for there to be sufficient capacity at the NHS to manage these things and make sure that people are properly cared for ultimately, and that people aren't forced into that situation where they feel like they have to pay the money, particularly as you said, when it's from people's families and people that are in a pretty dire situation. That's not at all what we want to see.
Okay, look at I'm going to thank everybody and close things down. Thanks to the organisers behind the scenes in the NOA for organising this once again. Thanks to our three speakers and for the conversation and for the questions. And we will not be having a meeting in August. I'm just going to share my screen once again, if I can find it. Sorry, excuse me for 1 minute. I've lost my screen. Let me just find myself again. Here we go. Sorry, I beg your pardon. So share screen. That's me there. and it's just really about what's coming up. Can we see that, everybody? Yeah. Hopefully we can. 8th of July, there is a QuickAn Information Governance Workshop. These are available to members of the NOA. Wellbeing Workshop, 13th of July, 14th of July, Outcomes Initiative. And so the QuickAn is all about clinical audit network, quality improvement in the clinical audit network run through the National Orthopaedic Alliance. So please join us then. As far as these webinars are concerned, we won't have one in August, but we will have one in September, probably mid-September. Details to follow. So unless I've missed out anything, I don't know, Claire, are you listening in? If I've missed out anything, please say so. Otherwise, I'm just going to thank everybody for joining, and we'll see you in September. Thank you now. Bye now.